All right, so let's go ahead and while we're waiting for the governor, let's go ahead and start with Dr. Rheuban and our other presenters. And we're going to talk about telehealth while we're waiting for the governor to come on. The first thing, in general, we're going to talk about what's the difference between telemedicine, telehealth, and remote patient monitoring. Can you go ahead and address that? And I'll just leave that up to the panel. Dr. Rheuban, do you want to start?
Sure, and good morning to everyone, and thank you for the opportunity to collaborate on this panel this morning. So the question relates to the difference between telemedicine, telehealth, and remote patient monitoring. Essentially, telemedicine is the remote diagnosis and treatment of a patient via telecommunications services. Telehealth refers to a, oh no, am I cut off? Cliff, can you hear me?
Can hear you.
Okay, great.
You can hear you, Doctor.
Okay, great, thank you. Telehealth refers to a broader scope of remote healthcare services that support long-distance clinical healthcare, patient and professional health-related education, and remote patient monitoring. Other services such as e-consults, which are the sort of a codified, formalized curbside consult process. Virginia established in code the definition of telemedicine in 2010. In which it states, telemedicine services means the use of interactive audio, video, or other telecommunications technologies by a healthcare provider to deliver healthcare services at a site other than the site where the patient is located. And in 2015, the Board of Medicine issued a guidance document to that effect. Well, I see Governor Northam. Good morning.
Good morning. How are you all doing?
Good morning.
Thank you.
I'm sorry to keep you all waiting. There's a lot of moving parts here, as you might imagine. I'm sure it's the same in your world.
Well, thank you for joining us. Do you have some opening remarks? I have a couple questions for you, but I'm sure you have some things on your mind.
I will be brief. First of all, thank you all for all you're doing. This is as we say, we're in uncharted waters right now, and a lot of unknowns. I like to describe this as we're in the middle of a health crisis. We're also in the middle of an economic crisis, and the sooner we can get the health crisis under control and behind us, the sooner the economy will recover. But certainly our emphasis has been directed toward dealing with the health crisis. So our numbers continue to go up. We had 144 new cases, positives over the last 24 hours. We're up to 14 deaths, unfortunately. You all have seen the numbers across the country and across the world. So this is in no way have we reached our peak, and it's very concerning. As you all know, as healthcare providers, there are a lot of unknowns with this virus. We don't know whether it's seasonal. We don't have a vaccination for it. We don't have a treatment for it. So dealing with the unknowns has been quite a challenge. Two areas, angles I'll just kind of talk about that we're, coming at this with. One is the containment, and we have taken some aggressive measures, especially in our business community, encouraging people to stay at home, doing everything that we can to minimize the spread of this virus across Virginia. There's no question that it spreads more quickly when there are groups of people, so we are really trying to do everything that we can to discourage gatherings of people. The testing, and I won't dwell on this, but it's still a significant challenge. The turnaround time for our state lab can be 1 to 2 days at best, sometimes longer, depending on where the samples are coming from. A lot of the healthcare systems are now doing testing in-house. We have LabCorp and Quest, but the turnaround time that I'm hearing out there can be 5 to 7 days, sometimes longer. And as you can imagine, without the real-time data, it is very difficult, and it's very, very difficult for our providers who, one, don't know what the diagnosis of their patient is, and also if they start having symptoms and have to sit out or go home or quarantine, to not have the results for their testing for several days, it really affects our working staff. So we're continuing to work on the testing, but it's no question a challenge. As far as mitigation, a lot of challenges. PPE, let me just try to summarize as best I can what is going on. Everybody is competing for the same thing. Countries are competing for equipment, states are competing, the national government is competing, and healthcare systems are competing. And I have just really leaned into the administration in Washington to take control of this and oversee it. But it's, you know, we're reaching out with procurement to different vendors, but again, everybody is doing the same thing. But there's no question that as this ramps up, that is going to be a real issue in not having the equipment that we need, whether that be PPE, ventilators, etc. Another issue is bed space. Right now, we haven't, I think we haven't gone past our capacity, but we're working with FEMA, we're working with our Corps of Engineers. The challenge there is going to be how to staff these alternative sites. And so we're putting a plan in place for that. And then finally, the staffing is certainly an issue. And we're working with our volunteer corps, we're working with our community colleges, trying to train up individuals, even like fourth-year medical students that have already completed their courses and are ready for graduation to get them on board. So that's in place. So a lot of planning, a lot of moving parts, but I think it's a given that this is very serious. It's not going to go away by Easter. Unfortunately, we're looking at a couple months at least, and maybe even longer than that. So that's kind of where we are in the medical world. There are obviously things going on with the economy, things going on with our children, their education. So a lot is on our plate right now, but we have a great team. They're working very hard, and we'll get through this together. So I'll be glad to try to entertain your questions or comments.
Thanks, Governor. What I wanted to start off with, this webinar is about telehealth, and as we go forward, you know, Medicare will reimburse, will accomplish two things for us. One, it allows us to use any technology, including phone calls, to conduct telemedicine. Yes. And then secondly, it reimburses at the same in-person rate. Anthem, and not to call out somebody specifically and throw them under the bus, but number one, they don't hardly pay anything. And then number two, they want you to use their proprietary technology. Mm-hmm. And so there's some things we can do at the executive level to remedy that.
Is your question, are there some things?
Yes, sir.
Yes, well, we've tried to set an example by what we're doing with Medicaid, and certainly encouraging the other healthcare systems to fall in line, but some are and some aren't. To your point, I will continue to do everything that I can to encourage them to do that. And there's some other issues, as you know, with telehealth, and I appreciate you all discussing that. I have been preaching for many years the importance of broadband across the Commonwealth, and we've made progress, but it's been a lot slower than I'd like to see. So I'll continue to work on that aspect of it, but also on the reimbursement as well.
Well, as I'm going to ask you another question about practice viability, but as we go forward, I mean, one of I think our concerns is workforce preservation as we try to do our part to continue to do the healthcare that needs to be done and abide by the social distancing things. It really hampers smaller private practices in particular from a revenue standpoint without being reimbursed.
Yes, I hear you. Talk to me a little bit about what you all are seeing on the ground. What's going on out there in your world, and let me know what I can do to help with some of that.
All right, I'm going to get some questions. I'm going to ask you one more, and one of those is, sorry, I got to log back in where my questions are, for private practice, have you considered mandating commercial insurers to pay out practice interruption coverage to pay out with the cost of this severe practice interruption? And it's usually linked to physical damages, but clearly this is a big practice interrupter.
It's no question. And I mean, you know, one of the things that we did was to ban elective surgeries. And this is not only affecting hospitals, it's affecting, you know, private practices as well. As you know, they're voting today on what they call the CARES Act at the federal level. We're looking to see what kind of resources come into the states from that, and specifically into Virginia. Aubrey Lane, who's our Secretary of Finance. So we will address that. I just don't know the numbers that I have to deal with yet, but certainly to protect businesses, to include our private practices, is very important.
Well, because one of the things that we hear is that offices are having to lay off staff as
Absolutely.
become. I know there's some things that are going on to help with some of that, with some of the disaster loans, but on a cash flow basis, most practices don't have a big float to work on.
Yep. No, I know it's a problem. So we're addressing it.
One question, I don't think anybody has the answer to this, but when can you expect the restriction on elective surgeries to go away? But I think that's going to be a while.
Let me just touch on that. We have daily briefings. Yesterday, I was on a conference call with our president, our vice president, and his consultants, some of whom are epidemiologists. And I specifically asked the question, I said, you have access to the best data out there. We obviously have good data as well. I said, give me your best case scenario and your worst case scenario. And she wouldn't answer my question. So we are dealing with a big unknown. And while the president would like us to get back to normal, get the economy up and running as fast as we can, I would like that as well. But I think we have to be honest with Virginians and Americans and tell them this is not a matter of a couple of weeks. This is not a matter that people will be back in congregations on Easter Sunday. I don't know all the answers, but we need to prepare for the long haul. So that I don't have an answer for your question, but it's not going to be in a few weeks. I can tell you that.
Is there one question? This is a sort of a telemedicine question. I have a lot of questions for Dr. Rheuban as we get forward. Well, I think that's, let me see if there are any more specific questions for you, Dr. Northam. Somebody asked, why not go ahead and shelter in place and not wait weeks from now?
Yeah, I think it's a matter of semantics. We're essentially doing the same thing that other states are doing, whether you want to call it shelter in place, whether you want to call it lockdown, shutdown, whatever. We have closed down non-essential businesses, recreational and entertainment businesses, and encourage people to stay home. I think anybody realistically that says, well, let's lock down or shelter in place, the reality of that is, how do you enforce that? And we have a society that we're all creatures of habit to tell people to stay in their homes for 3-4 weeks, months. I mean, that's what we're dealing with. So I think we have to be realistic and continue to encourage Virginians to do the right thing. That is to maintain social distancing, to wash their hands. If they're sick, to stay at home. Those are the things that we need to concentrate on rather than talk about the semantics of how we approach this.
Thank you. Can you talk a little bit more about the Medical Reserve Corps?
We have a few thousand people. We just last week had about 1,000 people sign up. I don't have the email. I can get it to you in just a second on how people can contact if they're interested in volunteering, but we need to expand on that. We have an organization for that, but that's where I see the real limiting factor is if our capacity at the hospitals is overburdened, we're going to need the staff. And so we have a list of volunteers, and we also have in place how we're going to train up those individuals.
Another question coming in is, can Virginia delay income tax payments?
You have all my favorite questions this morning. We have postponed the payment for income taxes to June 1. We are on a different filing schedule than the federal government. And let me remind everybody, Virginia cannot print money. We have to balance our budget. We have to keep our essential businesses, our essential services going forward. So we have postponed the payment. You still have to file, but the payment is not due till June 1. Depending on, again, what kind of assistance we get from the federal government, we may be able to extend that. But right now, today. It's June the 1st.
So more questions about the Medical Reserve Corps. We talked about that. Let's see. Again, more people. We just want to beat Anthem over the head about paying for telehealth as a major, limiting factor.
Let me just repeat the as far as the Reserve Corps, it's vdh.virginia.gov/MRC.
Thank you, everybody. We'll put that on the website later on today. One of the questions that somebody asked is the Virginia Disaster and Advisory Committee providing guidelines on ethical decisions regarding resource allocation and particularly ventilators?
Yeah, we haven't got to that point yet. We just had a meeting. That's why I was a little bit late. Talking about if our capacity gets as such, how we're going to make decisions on who receives care and who doesn't. And I've been down that road in the Army. I see you have as well. But we're making plans for that. I would like to say we won't get there, but if we do, we'll have a plan in place.
Several other comments, Governor, just to say thank you for your leadership. Just not questions, but just commentary from the peanut gallery.
Well, that's very kind of you. I'm glad to do what I'm doing, but I appreciate you all doing. You are truly the heroes, and I've been in your shoes. I look forward to being back in your shoes in a couple years. That's what I'm trained to do, but it's tough work that you all are doing. You're putting yourself at risk, you're putting your families at risk, and as I said, we're in a time that we have never seen. We are fighting literally a biological war right now. So I appreciate all you do, and just keep up the good work. And I can tell you that we're working around the clock here and doing everything that we can to support you. I know everybody has their own situation, has their own questions, and we'll do the best we can to deal with those. But we're just going to all have to be in this together for the long haul.
One question is there a way to incorporate recent retirees that are into the licensure network? I know I just got a notice from the Army that they were accepting voluntary recalls from active duty for certain critical care physicians and nurses.
It's a great question, and yes, there is, and we've had a number of people step up and want to volunteer. We have to keep in mind this is a virus that so far is harmful to the elderly. And so we're really trying to encourage young people because they're less vulnerable to the virus. But, if there are folks that are willing to help the older age range, that is very helpful. I was looking at the statistics this morning. 73 of our 460 positive cases, so 73 of 460 are between the ages of 20 to 29. So this affects young people as well. Again, their outcome usually is better than the elderly, but it does affect everybody.
I've seen on a part of some group chats where their groups are collecting PPE from folks that have it, either from offices that are not using it right now. And some Dr. Chung asked if there was a way for the state to help us to coordinate the collection of some of that and then redistribution of that PPE.
There is, and there have been a lot of people that have stepped up to do that. I will make sure to get back with you on a phone number or an email that people can go on and make sure that it gets to the right place. But we are working on that as well. And there have been a lot of people that have volunteered.
A lot of questions from private practice folks just about how do they interact and get some of the PPE of whatever small amount is available.
Yeah. In other words, if they need to more supply?
Yes, sir.
Okay, I will get contacts so that if they need it, I tell you the challenge is going to be where to get it from, and that's something that we're working through each day. I don't want to sound like a broken record, but everybody out there right now is competing for PPE.
Are there any innovations that we're looking at the state level as non-standard alternatives to PPE?
Yes. I mean, for example, our penitentiary system making about 30,000 masks per day. And the way we do this, they have to be tested and make sure they meet the standards. And so the Virginia Department of Health, we actually have sent state police across Virginia to pick these samples up, come back. When I say samples, the masks that are being made, bring them back to Richmond. We're testing them. So there's a process in place to do that.
Thank you. There was, I was particularly thinking about the university. I know VCU has a Center for Innovation, and just sort of putting some of those resources to work to find
Right.
some alternative. I had one of my patient's wives. I called him to tell him I was canceling his surgery, and she was sewing a mask for the sheriff's department. And said, well, maybe you could put a panty liner in or some other non-standard thing. And I can't speak to the efficacy of that, but.
Yeah, no, exactly. I think people are being very innovative. It's just before we, say it's okay to use this, it has to be looked at and meet their qualifications.
So another question is, somebody asked that the restrictive policies in place for immigrant physicians relative to their visas, and could those be waived for the pandemic?
Yeah, that's being looked at. That's a federal decision, but it's certainly being looked at. And by the way, yesterday I talked to our entire congressional delegation. I do that once or twice a week, and they're working as hard as they can to solve some of these very issues that you bring up.
Just a couple more thank yous there. You've been making a slew of emails after this because you asked the question early on about what you're hearing on the ground, and most of the things I'm getting on my chat are questions, but to answer that question, what people are feeling.
Yes, I appreciate that.
And then one question came in about, could you clarify what types of services are limited by the most recent executive order?
When you say services, as far as businesses?
Yes, sir.
Yeah, what I would do, rather than going through all that, if you go look up Executive Order 53, that goes through all the details of businesses of entertainment and recreation, what's essential, non-essential, using 10 or less in a confined space. So it kind of goes through all that in detail. And Marvin Figueroa is with me. Now, what I'll do is make sure to get some of these emails and ways of finding out this information to you, so you'll have answers to those questions.
Thanks. Here was another suggestion about using shower curtains and plastic tablecloths to sew PPE gowns. So, I mean, even on the chat, we're doing committee work trying to sort of solve some of the. Another question was, can VDH help identify which lab tests other than LabCorp Quest would be okay to use? It seems like there's so many other tests proliferating, whether those are all FDA approved, we assume?
Yes, I think what we've seen a lot of in Virginia is UVA, for example, VCU are doing in-house testing. Centera is close to being up and running with their in-house testing. So we'll continue to do our testing through the state lab, but I think it's going to require, if we're going to really ramp up the testing capability in Virginia, and especially improve the turnaround time, it's going to have to be done through the private sector and through our healthcare systems.
Well, we really appreciate you taking so much time with us this morning. We know you've got lots of stuff going on.
Well, I appreciate it. I'm glad you're smiling, and remember, through this, we have to keep our sense of humor, and you all are great people, and you're very talented. So Virginia needs you. So stay strong and take care of yourselves, take care of your families, and together we'll get through this. So thanks for all you do.
Thank you very much, Governor Northam.
Appreciate it.
All right, so we're going to go back to Dr. Rheuban and the telehealth questions. If we could get Anthem to pay for some of the telehealth, that would be a great victory out of today.
So we have some really terrific other panelists as well. Can you hear me, Cliff?
Yeah, go ahead. Yeah,
okay,
sorry,
go
ahead.
No, I was just going to say, we briefly covered the definitions of telemedicine and telehealth. many of the questions that have been submitted relate to reimbursement of telehealth, but also and telemedicine. And I will say, prior to COVID-19, it has been a patchwork of reimbursement policies at the federal level in Medicare, at the state level in Medicaid, the commercial payers as well, employer-directed plans. But what has been fairly amazing is the rapid transformation across the various payers, which will allow for providers to be reimbursed. And again, I know you mentioned one particular payer, but I think things are moving along very quickly. And the force of all of us together will help to make that happen. I would like to make a quick comment about why telemedicine is important in this coronavirus pandemic. The goals of telemedicine would be to improve access to care for patients, especially those who would be adversely impacted, those with chronic illness, who really shouldn't be coming to offices where they may be exposed. Telemedicine can reduce the need for patient transfer because we can support providers and patients in community settings. We can monitor patients with telemedicine who are in home quarantine and who are coronavirus positive. And it can reduce exposure of the healthcare workforce and then reduce the need for personal protective equipment by virtually seeing patients. We have a question about, for those physicians who've never used telemedicine before, what tips can we offer? We have a lot of fabulous resources, and I want to point to the Virginia Telehealth Network, our Mid-Atlantic Telehealth Resource Center housed at the University of Virginia, and I'd like for Chethan Bachireddy to speak to that. The Medical Society is a resource. The Virginia Hospital Association is a resource. The National Telehealth Resource Centers, and even at UVA, we have a training portal for which we give CME and ANCC credit called Telehealth Village. So there are a lot of resources to be made available to practitioners in the Commonwealth of Virginia and beyond. Kathy, would you comment, please, about Matrix?
Yes, so the Mid-Atlantic Telehealth Resource Center, which is actually housed at UVA, is a federally grant-funded resource center, and we are available to any provider wanting to do this. And I'm going to put into the question chat box, responding to everyone, that we do have, and I know that MSV probably has put this on their website link as well, but we do have a resource page at our website. It's matrc.org, specifically outlining all of our frequently asked questions and frequently requested resources like consent form templates and all that type of thing on our website right now. We've been adding it and updating it pretty much hourly as new things come in. So it's matrc.org, and we have everything from training videos on how do you do this telemedicine thing to answers to a lot of your reimbursement questions and links to the original source documents for many of the reimbursement questions. So if you can't find the answer there, we also have links to how you contact us to ask questions and to get technical assistance. We're also offering virtual office hours almost every week, as well as several recorded trainings. So please take advantage of that.
All right, what I'd like to do is if we could go to Dr. Brown for a minute to talk about licensure issues, and then to Dr. Bachireddy to talk about the Medicaid DMAS point of view. Dr. Brown?
Hi, thank you, and I'm trusting you can hear me as well.
Yes, thank you.
So
the
good news is, I think the licensure issues for everyone on this call, because I assume everyone on the call is licensed in the Commonwealth of Virginia, are minimal. Especially if you're dealing with established patients, you can pretty much use any type of technology that works for you, from phone call to what's now being allowed federally with some relaxation of HIPAAs or things like being able to use your phone, being able to use all types of video platforms. And so I'll defer to answer questions people might have. The big reminder is that the standard of care in telemedicine is the same as the standard of care in medicine, which is we all need to do what we need to do to ensure we have the right information we need with each and every patient, and so we can make informed clinical decisions. And so with that, I'll defer to, because I think the technology issues are really the ones that your listeners may want to hear more about.
Can we talk about med malpractice just for a second? And that is, Virginia has in place, and my understanding is that in the event of a declared disaster, there is immunity from simple negligence.
Well, if you're asking me that, that's not a section of the code I'm particularly familiar with, so I'm going to defer answering. I'm sure some of the experts at the Medical Society have that answer at the tip of their fingers, though.
All right, I'll defer that to the next question. Dr. Bachireddy, do you want to talk about DMAS point of view?
Yeah, thank you so much. Can you guys hear me okay?
You're live.
All right, fantastic. Well, thank you guys for allowing me to speak, and you know, certainly for your interest in telemedicine. Before this panel, I asked if a survey could be sent out on telemedicine and where MSV and the docs within MSV were, and I was pretty astounded. I was just looking at the results earlier this morning that 80% of you are already thinking about, or not even thinking about, performing telemedicine services and are looking to ramp up those services in the face of this crisis. And so, to what Governor Northam, Dr. Rheuban pointed out, it's not, you know, it doesn't really seem like it's an option to move to telemedicine as much as an imperative, just given the you know, the state we're in, both with the spread of infection, with the lack of supply related to PPE, the fact that patients and providers are nervous about face-to-face visits in the clinic. And we've already seen in parts of Virginia, some clinics limiting their hours or even shuttering for a few days to figure out how they adapt. And so this is really requiring leadership on all levels, not just the federal and state, but also the local, clinic, and individual levels. Certainly unprecedented times. At the DMAS level, what we've been up to in Medicaid is, and just for a little context, I'm a practicing internist, do primary care addiction medicine, and also the chief medical officer at DMAS, for those who don't know me. So what we're up to at DMAS is really we made a couple of changes late last week. One of them is we're working to ensure more continuous Medicaid coverage, covering COVID-19 testing, although supply is still an issue, waiving copays for patients, allowing 90-day fills on pharmacy and early refills, extending and waiving certain service authorizations, for example, for CT chest, home oxygen, home health. And the final, and the one that all of you are here to hear about, is really expanding telehealth options. And so the most important, you know, I think Dr. Brown said it well, that a lot of the same rules that would apply to face-to-face visits also apply to telemedicine visits. And so what we've done on the DMAS side is made a couple of key changes. One, a patient can be at the home, and so can a provider, as long as that provider and patient are in a private setting. And really that's to protect health information. The second is that you can use phone or you can use video conferencing. The third is that if you use phone or video conferencing, the payment will be the exact same as an in-person visit. So I just am going to repeat that. You can use phone or video conferencing, and the payment will be the exact same as an in-person visit. The last point related to that is we also wanted to make billing and documentation as simple as possible. We know that moving from 0 to 100 with telemedicine can be very challenging. It can be confusing, and so at least on the billing part in Medicaid, we're just asking, bill as you normally would an in-person office visit, and just as long as you document somewhere in your chart the alternative location used and that the service delivery was via telehealth. And let me dig into that a little more. So if you are a sophisticated telemedicine user like Dr. Rheuban, then by all means use the telemedicine codes, the appropriate modifiers, the place of service, 02 for telehealth. But if you are not, if you're new to telemedicine, we are allowing and supporting providers to bill as you normally would an in-person office visit. Now, this is really for the duration of the crisis. Over time, we will want you to bill more appropriately for telemedicine. But again, we believe it's not as much of an option as an imperative to move to telemedicine. And so we want to do everything we can to make it as simple as possible. So I'm going to review those points because I spoke, I think, fairly fast. So patient can be home, provider can be home, just as long as it's a private setting. You can use a phone call or you can use video conferencing. I spoke to some FQHCs yesterday and they rapidly moved to phone calls. And so that is allowed, encouraged. The goal is really to provide care to patients. You'll be paid the same, whether it's a phone, video conferencing, or if it needs to be in person. And then for billing and documentation, yes, you can bill the telemedicine codes if you are able to, but if it takes time for your system to get up and running, don't let that stop you from moving immediately to phone or video conferencing. And you can bill as you normally would an in-person office visit. So I'll stop there and then happy to take any questions.
I just would like to say thank you for DMAS for taking such a leadership role in this. Clearly, although these, just to clarify that what the rules that you're talking about particularly apply to Medicaid patients. And with some hope, there are a few chats are coming in that Anthem, they've been so moved by our call this morning that they may in fact cover some of the things that we're talking about as my phone's blowing up because they don't want to get beaten by the governor. So, but we will hopefully work on those folks. And then those are covered, those are similar rules for Medicare is my understanding. Is that right, Karen?
Yes, that is correct. Medicare has been pretty proactive. They originally had some originating site restrictions, which have been reversed for purposes of COVID-19. As an example, E&M visits would have to be conducted with the patient originally at a rural originating site. They eliminated that. They have included expanded number of services. Medicare, and one of our pleas has been for alignment across all the payers, right? It's hard for practitioners to track which payer covers which service, kind of what you were referencing with the particular commercial plan you were discussing. But Medicare has broad coverage for such things as remote patient monitoring, e-consults, and we are hopeful that that will also potentially be covered by our Medicaid plans as well. And Chethan, I don't know if you want to discuss the potential of additional guidance coming forth from Medicaid.
Yeah, I can speak just a little bit on it. I mean, we're still working through the details of that, but really what we're looking at is at least around instead of purely traditional visits through telemedicine, we're also looking at the potential of e-consults, phone-to-phone consultation. As Dr. Rheuban pointed out, e-consults are really a formalized curbside consult. As we expect, the need for physicians will go up, and the supply will maybe go down a little bit. We're really trying to gear ourselves up for how we can be as efficient as possible from a healthcare delivery perspective. And then the other piece we're looking into is remote patient monitoring. And I feel as if Dr. Rheuban is the expert in the room on this, and so she can speak to that and potential use cases in the context of our current crisis.
All right, before we go to that, let me interrupt in just one question, and that is, so the Medicaid covers well-check codes or just sick codes, or both?
So yeah, both all. So for the services that we currently pay for, you can, with the exclusion of a small number of behavioral health services, including therapeutic day treatment, the vast majority, 90+%, and this is listed in our memo as well, and certainly all routine office visits, sick, addiction, behavioral health, can be covered via telemedicine in the ways that I described: phone, video conferencing. The other thing, small point I want to highlight, is it doesn't have to be an established patient. It can be a new patient as well. So if there is someone who has concerns for COVID-19, who hasn't, you've never met before, we are allowing, and I believe, and I'm almost certain that Medicare is also allowing for new patients, not just established patients. And so just wanted to highlight that. The other thing I just wanted to highlight real quickly is that you can prescribe controlled substances as well via telemedicine. And so this is, I know some of the questions we got actually in the survey was whether that was possible. And so that is possible. Certainly the same restrictions and limitations and considerations apply as would in a face-to-face visit, but that's possible during this crisis to, for example, prescribe Suboxone for a patient with opioid use disorder, possible and certainly encouraged, as a lot of folks won't have regular access to care.
All right, Karen, go ahead. I cut you off before you were going to go to the next thing.
Oh, well, one other thing I wanted to, Chethan, if you could clarify that this was going to be retroactive to the emergency order, is that correct?
Yeah, so yeah, Karen, thanks for bringing that up. I think so 2 points I want to make. So the first is to directly address that point, Karen, which is these policies will be retroactive to the governor's declared state of emergency, March 12th. So that's one. The other is that on the Medicaid side, we contract with 6 managed care organizations, so we're aligning the policies across those 6 managed care organizations, and they are just going live with their systems to accept our policies, I believe yesterday and today. So they should be live with those policies today. So it takes them a few days to incorporate our policies into their system, but they are live now. So just wanted to make that point.
I could make another comment about remote monitoring and the types of patients who would, a number of us have provided input to Medicaid to identify specific conditions that would be amenable to remote patient monitoring. And they include such conditions as chronic illnesses like heart failure and diabetes, transplant patients, medically complex children, COPD, high-risk pregnancies, and we hope to hear how Medicaid will manage that. But very important, because we want to eliminate the need for multiple visits back either to the emergency department for chronically ill patients who would be all the more at risk if they are exposed to coronavirus. In addition, we're using remote patient monitoring tools to help manage patients in the home who are coronavirus positive, who we don't necessarily need to have come back and forth to clinic facilities, and they can be managed with remote monitoring tools and remote examination tools as appropriate. One other comment I want to make, and perhaps David Brown will also comment, but the Federal Office of Civil Rights has waived HIPAA enforcement action for the use of non-HIPAA compliant video conferencing technologies. And David may comment to us about how the Commonwealth is approaching as well. So in other words, during the period of emergency, if you do not have HIPAA compliant devices, and there are many inexpensive HIPAA compliant software solutions that can be acquired for the practitioner, and then all you need to do is document. You don't have to sign up for a major service, but we can also in this period of time use such services as FaceTime. And David, would you affirm that that is true currently in the Commonwealth of Virginia?
Yes, indeed, it is true. In fact, the Board of Medicine has placed that federal directive on its website to make sure everyone is aware that the federal rules have been relaxed during this crisis.
Before we drop a lot of people on the call at 9 o'clock, I just wanted to clarify about Anthem. They sent a note actually that they are covering. I misspoke when I said they are not covering. That their reimbursement for telemedicine was at a lower rate. We will post on our website later this afternoon, and they've also put out in their provider news the specifics of their coverage, but they are waiving cost sharing for telemedicine services for providers. But they want you to use Live Health Online, but they say you don't have to use that exclusively, and we'll post all the details on our website. And again, that's also available on the Anthem provider news. There are some details about Medicaid and other various things, but I want to just be clear about to correct what I said earlier about reduced reimbursement for Anthem.
Cliff,
right,
this is Karen. Our Senate Bill 675 in 2010 was a private pay parity reimbursement legislation. So we are covered in the commercial plans at parity for in-person services.
All right, so we're at 9 o'clock. We're going to start to drop off. I just want to go around the panel again to make sure that any last comments, Dr. Brown?
I don't have any last comments. Certainly, if practitioners have questions regarding any licensure or regulatory issues, But essentially, I think it's a for Virginia physicians. I think it's a pretty clear field in terms of the regulatory process.
Kathy, Dr. Wibberly.
Yes, I just wanted to just make sure that people are directed to our website because so many of the questions that are being posed right now are there. So visit.
All right, Karen.
I just want to say a couple things, and the Commonwealth of Virginia has been incredibly supportive of telehealth, and as has the Medical Society, the Virginia Hospital Association, and how lucky we are to have a physician for a governor.
Truly, at this time, I absolutely agree that is fortuitous that Dr. Northam is in the governor's mansion, and appreciate all of his leadership. I'd like to just conclude by saying thank you all very much for joining. If this has been helpful, let us know. If there are other questions that you want answered, you can email those to governmentaffairs@msv.org, and we will get those addressed. This recording should be on our website at msv.org this afternoon. Clark, any other last comments before we end?
No, sir. Greatly appreciate everyone being on, and we're going to put this up on msv.org/COVID-19. We've had 3 webinars, 1 a week, and so we hope to have one next week. Of course, the tricky thing is finding people with free time to do it, but be on the lookout for what comes next. Thanks a lot.
All right, thank you all very much for joining us. Have a great day. Be safe. Wash your hands.